Can I call all the speakers to come up to join us, because we will have time for discussion, 10 minutes. When you have a question, please introduce yourself and make the question as short as possible. Please, can you give the microphone to Dr. Walid? The microphone for the auditorium. Microphone. Yes, Dr. Walid Bsata.
Yes. Thank you very much. I mean, very excellent session and very excellent presentations. I have two comments, really. I mean, not a question. The first comment related to the presentation of Dr. Lutfi Al-Qurabi. I mean, he mentioned very clearly that what is the difference between expert and specialist. I mean, when we say that we want to refer a patient to an expert, I mean, this is very good, but in our meaning, that probably expert is the same as specialist. Why? I mean, اسأل مجرب ولا تسأل حكيم. I mean, we don't want somebody who has certificate. We want somebody who's very experienced in the management of hypertension. He might be family physician, he might be nephrologist, cardiologist, or whatever. I mean, in my feeling that it will be very useful if many of the hospitals, they have hypertension clinic. This is where we have experts in the management and following the guidelines. The other point really or comment is related to when we say which drug we need to use. I mean, always in my mind that we need to know that our patient is not non-compelling indication. The majority of patients with hypertension, they have compelling indication for some medications because they have many comorbidities and risk factors. I mean, for the assessment of this one, this will tell you exactly which drug you need to use. I mean, when we say that beta blocker, really, it is number 5 in the use for management of hypertension. It might not be very correct in many patients because, for example, in diabetic and obesity and whatever, they have sympathetic overdrive, where they have heart rate is slightly high, where we need really to use beta blocker in addition to our medication. I mean, dyslipidemia related to beta blocker is not very high, and if you will measure this one, you will feel that it is much better to use beta blocker in addition to medications. Thank you.
May I ask the panel? You know, the targets of control of blood pressure are very moving variables. Guidelines every now and then decide another point to control. And for diabetics specifically, this target is debatable. Whether it will be a control of less than 40, 140 over 90, or 130 over 80, or even 120 over 75. And I want to know the recent update over the debatable target control. If any, Dr. Abdul Qawi, have any?
Yeah, I like the definition of expert and specialist. Okay, I think expert the guy who thinks he knows and he doesn't know. Okay, that's the. But usually, if you have, for example, a case of hypertension which is complicated, I think it depends on what is the cause. If the patient has a nephrology problem or renal problem, I think he should be referred to a nephrologist. If a patient has something which is related to adrenal, it should be referred to endocrinologist, okay? So, or cardiologist, of course, if there is a cardiac problem. So I think this is much better. But in general, hypertension, there should be a hypertension clinic in any institution in which the one who's there, he will face most of the problems, and he will refer.
Dr. Hussein, please.
I would like to comment on the target of blood pressure. Dr. Abdul Qawi nicely mentioned that the ADA is still sticking to the 140/90, even though they are recommending that in some patients with high risk, they will recommend 130/80. And now almost across the most of the guidelines, really it's 130/80.
Yeah.
The American guidelines, even the European guidelines, 2018, mentioned in high risk patients, including diabetic, 130/80. And our SHMS guidelines even, we mentioned specifically in diabetes that it's 140/90, however, 130/80 is warranted. And this is before the AHA guidelines. So I would agree, maybe in diabetic patients, I would be going more for 130/80.
And for
actually.
chronic kidney disease patients?
130/80.
The same. Do you believe
Especially with proteinuria, of course.
Do you believe in the lower the better?
Sorry?
Do you still believe in the lower the better?
Yeah, I think in diabetic 140/90 is well established for many reasons. We remember a long time ago we said 140/80 because of the HOPE study, which showed that there is a reduction of mortality from reduction of diastolic blood pressure from 90/80, but this was not reproduced in any other study anyway. Okay, so if the patient does not have any other risk factors, 140/90 is very good range. If he has other risk factors, I think we will try, but we will also follow up the patients if there is dizziness, if there are unchanges, for example, in other medications. And sometimes it depends on the medicine. If the patient takes a small dose and I can increase and get better target, it's okay. But I think if a smaller target or a smaller target achievement will get with increase, adding another or third medication, I will be resistant to.
Please.
The question of going to the lower target of below 130/80 comes from the SPRINT, which is in a high-risk patient, which is really fair enough because that was a positive study, and those patients with below or the high risk of a cardiovascular disease, they benefit from a blood pressure below 130/80. However, there is another statement that you really have always to consider, which is that the side effect of this, and if you are not going to follow the patient closely, then the patient may be in troubles. Acute kidney injury is common, those patients, hypotension is common, syncopal attacks is common. So those patients...
It's working.
So, it's already close. So those patients, if you're really going to go to 130/80, they need to be followed closely for the acute kidney injury, for the hypotension, and the...
It's not clear. Can you come here?
Thank you.
If I just want to repeat what I said, that those patients, if you're really going to go to the lower target, please just make sure that you follow the patient closely for the acute kidney injury, hypotension, and syncope. We just have a patient who was stuck. It was like 50 or something like that. So this is the one that close monitoring is very important as well.
I have a small comment. I found the presentation of Dr. Lutfi very interesting. He mentioned the patients taking multiple medication, but the blood pressure was high. and he was admitted, and we found that he was taking nothing of all the medication. It's important not to prescribe another medication, to ask the patient if he is really taking the medication. That remember me on a patient with headache, with chronic headache. When he was taking Panadol, he's saying, I have always headache. And when I asked him, how are you taking the Panadol? He said, I am putting them under the cover of my head. So it would not function. Make sure the patient is really taking the medication. If we have a last comment or question from the auditorium, please.
Yes. The mic is not working. Mics, please. Mike. حاجة غريبة جدا. البطاريات.
I like to stress the point that Dr. Al-Mansari mentioned about taking the antihypertensive in the evening, because there are so many patients who ask about this and they get different answers from different physicians. And I think it's also more important to do so when the patient has renal disease, because patients with renal disease would have higher blood pressure at night. And you know, most of the strokes and the complications of hypertension occur early in the morning, because this is the highest pressure you would have.
Yes.
So I think then that the medication will be at the peak at that particular time. That's one thing. The other thing is about the beta blockers. Probably cardiologists would agree on that more, is that you see lots of patients who have hypertension with sinus tachycardia.
Yeah.
And I think these patients would benefit from taking
Yes.
beta blockers, or if they have ischemic heart disease.
This is one of the indication of beta blockers.
Yes.
If you have compelling indication, like this one, then they should. However, the studies about beta blockers are very old and doesn't include those new beta blockers which are more selective than the others. And we don't have any recent studies about beta blockers. I think it's money. It's money talks.
No, but there are patients who need it, like patients with ischemic heart disease and maybe sinus.
Yes, of course.
The other thing, as nephrology, we have seen lots of complications in patients who take aldactone with ARB, particularly if the creatinine exceeds 2. They can get fatal hyperkalemia.
Yes.
So it's very important to know that aldactone, whatever dose it is contraindicated if the creatinine more
It's
than
a red flag. Yes.
If creatinine is more than 2, we should not give it.
Yeah. Okay, and last question here.
Good mornings, and thank you for all. I am Dr. Musa Al-Gharabli, internist physician from Al-Jouf area. Yesterday I asked at the last meeting, my questions, small questions to my colleagues, and I referred to our nephrologist today. So my about the combination use of ACE and ARB together in the management of diabetic nephropathy. Is there any place for this combination of both categories, of the same categories at the same time? This is the first question. The other question, small also, if there is any serum creatine level cut off, when at this level, for example, 3 milligram, we have to start to think to reduce these drugs or to withhold 2 of them or 1 of them out from the regimen of antihypertensive drugs. If the patient has diabetes, has hypertension, and start urea creatinine raising going up, is there any cut-off for the serum creatine level and the patient is on ACE or on ARB? Is there any level cut to stop or to reduce? Yes.
Last short answer, please.
So now there is no rule for the combination of ACE inhibitor and ARB. In fact, all the international guidelines now they're recommending to avoid the combination of the ACE inhibitor and ARB in the management of hypertension. In regard to your second question, is there any point that we can stop the ACE inhibitor or ARB in a patient when the creatinine is rising? The question is only if you're really suspecting a renal artery stenosis when the increase is more than 30% from the baseline. So when we suspect a patient having a more than 30, or when we see a creatinine is increased more than 30%, yes, we stop the
Can I ask the eminent speaker to come in front, beside Dr. Nabil and Najjar, to give them small present? And I would like to thank all the contributors, all the speakers for their patience. Please come join us. Dr. Akram? Dr. Lutfi. Dr. Badria. Dr. Hussam and Dr. Abdel Gawi.